Good evening, everyone. Welcome to our April 1st session of Food Literacy for All. Today, the panel is, we are welcoming three members of the panel on equity for first food and breastfeeding, Kiddada Green, Angie Sanchez, and Jaye Clement. We're very excited about the panel today discussion. First, just a few words of introduction. Food Literacy for All is co-led by myself, Professor and Chair of Afro-American and African Studies here at the University of Michigan, and Shiloh Maples, community organizer, seed keeper, and storyteller. The community partners that made this course possible are Jerry Ann Hebron from the Oakland Avenue Urban Farm, Winona Binham from the Detroit Food Policy Council, and Shakara Tyler from the Detroit Black Community Food Sovereignty Network. There are more team members that also make this course possible. Sami, who's the Food Literacy for All course coordinator, Taylor, who is the graduate student instructor, Sai, who is the Sustainable Food Systems Initiative coordinator, Dr. Leslie Hoy, who is the SFSI Advisory Committee, and Chris Taylor, or technology, and Tiffany, of Food Literacy for All grader. You can, Food Literacy for All is presented by the Sustainable Food Systems Initiative with generous support from the Center for the Education of Women, Francis and Sidney Lewis Visiting Leaders Fund, the School for Environment and Sustainability, SEAS, and the Program in the Environment, also known as PITE. You can find us on X and on Instagram, and the poll questions are on iClicker for students and on Zoom for community members. Remember that all the classes are filmed and available on our SFSI website. Today, I'm really happy to introduce the video of the week by Odiso Obiora, a senior in the urban technology at the Tubman School. Here it is.
In the United States, systemic inequity creates barriers to thriving even from birth. Trauma, defined as a deeply distressing experience with after effects, can be passed across generations, known as intergenerational trauma. Social worker and Indigenous community leader Cami Goldhammer defines intergenerational trauma as the transmission of historical oppression and its negative consequences across generations. Unfortunately, this trauma can create negative health effects for mother and baby. Shockingly, an immigrant African mother, like my mom, faces fewer childbirth risks than I or future generations of my children will due to medical oppression in the United States. Luckily, trauma's effects can be healed. Breastfeeding not only nurtures, but can also relieve traumatic responses built into one's DNA and reclaim an experience that is a sacred practice for many communities. Advocates are working to ensure that all mothers, especially those in underserved communities, have access to breastfeeding support. And even if we don't plan to have children, we can all help create a healing environment where every baby feels safe, loved, and secure.
Thank you, Odiso, for this thought-provoking and beautiful presentation this week. And now up to Taylor to come and for the introductions and the poll questions.
In the United States, systemic inequity.
That happens every week. I've been looking forward to this panel since joining the team, and honestly, even before joining the team. And it's a huge honor to introduce our panelists today. So we will start with Kiddada Green, the founding executive director of Black Mothers Breastfeeding Association, an organization she established in 2007 to support Black mothers in her community. With a background in instructional work within Detroit public schools, she has leveraged her skills in education to lead national efforts in breastfeeding advocacy, racial justice, and maternal health. Kiddada's influence extends nationwide through initiatives like Black Breastfeeding Week and the Black Breastfeeding Caucus, both of which she co-founded to elevate Black families' first food experiences. Kiddada holds degrees from Michigan State University and Oakland University, and she continues to be a passionate leader, consultant, and advocate for Black maternal and child health. We also have Angie Sanchez, Crane Clan, Ojibwa and Odawa from Michigan. She is a PhD candidate in the Department of Geography, Environment and Spatial Sciences at Michigan State University. Angie spent the majority of her professional career as a business analyst using data to inform decision makers on better ways to operate the business. After having her first and only child, Angie switched gears and returned to school to study health and medicinal geography, where her research focuses on increasing access to breastfeeding support resources in Indigenous communities. During her first year as a PhD student, she was awarded a Michigan Health Endowment Fund grant of $338,000 to bring the Indigenous Breastfeeding Counselor Training Program to 6 different Indigenous communities in Michigan. In 2022, she helped author a grant to collaborate with Michigan Breastfeeding Network to help organize the Sacred Bundle Birth Worker Collective and position them as a nonprofit and single source for birth work support and Indigenous people in the state of Michigan. And last but not least, we have Jaye Clement, the Vice President of Community Health Programs and Strategies at Henry Ford Health, who oversees initiatives aimed at improving community health and equity. Since joining in 2011, she has led key projects like the WIN Network, Detroit, and the Community Health Needs Assessment. Jaye holds dual master's degree in public health and public policy from the University of Michigan. She chairs and serves on several boards, including the Michigan Community Health Worker Alliance. Recognized by Crain's Detroit Business in 2021 and 2023, she was named a notable rising star in healthcare and a leader in diversity, equity, and inclusion. Jaye is a lifelong Detroiter dedicated to advancing health equity. I'm so grateful to have all of you here, and I think it's especially incredible that you're all so local to where we are right now. We've had speakers from all over the place, and so pretty special to have a Michigan team here today. Before we get into the panel, we are going to do our iClicker questions. So these first 2 questions were just sort of gauging what you know, maybe based on any reading you've done, the video that you watched this week, but more broadly, just seeing where we're at. So starting the poll here, if you're a community member, we invite you to engage with the poll through the Zoom feature, polling feature. If you're a student, please use iClicker as usual. All right, so question 1, if a baby is not able to breastfeed, whose fault is it? Is it the baby's fault? Is it the birthing parent's fault? Is it the birthing parent and the baby's fault? Is it the dad or the non-birthing parent's fault? Or is it none of the above? And we usually wait until we get to about 185 responses. Right now we're at 150. We'll give it maybe 10 more seconds here. We have pretty equal responses, both in the class and in the community. Majority of folks are saying E, it's nobody's fault. Second most common response at 13% in the class is B, birthing parent. All right. The correct answer is A. It's the baby who's making decisions here. How has the breastfeeding initiation rate, sorry, technical difficulties. How has the breastfeeding initiation rate for Black infants in Michigan changed from 2012 to 2022? Has it A, increased from 60 to 68%? Has it stayed the same at 68%? Do you think it's decreased from 75% to 68%? Or maybe it's increased from 68% to 85%? Option E, it decreased from 70% to 60%. Let's see what folks know, what they think. All right. Most of the community members are guessing that it increased from 60% to 68%. Most of the class members are thinking that it decreased from 75% to 68%. So let's check it out. A, it's increased from 60% to 68%. I'm really excited to learn more from this panel. I will pass it on to Shiloh now, who will get us started.
Thank you, Taylor. At this time, I'd like to welcome our panelists to join me on screen. I'm so excited to talk to each of you this evening. Thanks again for joining us. So I was hoping that we could start off just taking a few minutes to, I guess, invite each of you to say a little bit more about your work and what brought you to this path. So is there anyone that would like to go first?
Sure, I'll go first. So as mentioned, I'm a PhD student right now at Michigan State studying health and medical geography. And I do a lot of things in the community. I'm a Indigenous full spectrum doula, Indigenous lactation counselor. I do research because I'm a PhD student. But really my biggest the end output is that somehow I'm helping my community members. That's really what drives anything that I do for the most part. What led me to this work was the breastfeeding journey that I had with my son. I gave birth to him 7, almost 8 years ago. And I knew that I wanted to breastfeed, but I really had no idea. I knew nothing about breastfeeding. I assumed, people have been doing it for 100,000 years. Like it's probably just as simple as breathing. Like it's not even a thing that you think about. But what I've learned since then is that it's a learned skill, and it takes learning. You have to actually practice it in order for it to be successful outside of, barring any other situations. And he had an undiagnosed tongue tie that went missed by several um, lactation consultants, by pediatrician, by folks who are allegedly in the know about breastfeeding. I went to several um, I went to several uh, resources to get help, and the gist of what happened was that I was dismissed. It wasn't in like a rude way or a mean way, but it was just, his latch looks fine. It shouldn't hurt. I was in pain, but it did hurt, and it continued to hurt. And so eventually I kind of figured it out on my own that it was a tongue tie just through research and being in Facebook groups. And so I was able to connect with an IBCLC, which is an international board certified lactation consultant, who suggested that that he be seen by a pediatric dentist or a ENT that has experience with tongue ties, because she felt that there might be some restriction there. So we did that. His tongue tie needed to be clipped. And then after that, I was able to breastfeed for the first time in 3 months. So he was almost 12 weeks old when that happened. And I was breastfeeding in excruciating pain the entire time. But I didn't quit because I knew that the milk was important for him. Breast milk was important for him. And so I just kept doing it even though it was painful. After that, I realized that um, it that should not have been my journey. It shouldn't have taken 3 months, numerous lactation consultants, whether it's IBCLCs or CLCs, or the pediatrician. It shouldn't have taken, me basically going to all these people, going to La Leche League, going to all these sources to try to get help, just to be told, well, I mean, it looks fine to me. There's not much we can do. It shouldn't hurt, blah, blah, blah. So I started reaching out to community members of my own community, and asked folks if they had tried to breastfeed, and they said they all did. And the answer was the same, that they quit very quickly. And it was because either they weren't making enough milk, or they had questions and they didn't have anybody to turn to. And I said, that is a problem, and I'm going to do something about it. And so that is why I'm here.
I'm so glad that you are, Angie. Thank you for sharing that story, and it's a story that resonates with me quite a bit as well. Kiddada or Jaye?
Hi, good evening, everyone. I am Kiddada Green, and I'm the founding executive director of Black Mothers Breastfeeding Association, where our mission is to reduce racial inequities in breastfeeding support. My inspiration for this work is similar to Dr. Sanchez, is that it reaches back to my own experience breastfeeding. But somehow it also overlaps with my life 13 years prior to having children. During my freshman year at Michigan State, I encountered a book called The Incidents of in the Life of a Slave Girl by Harriet Jacobs. And while reading this story, although I was already familiar with the practice of wet nursing, there was something that was really profound, and it ignited a profound realization in me. The story of how her grandmother, who was enslaved, had to wean her own child, which was the author's mother, so that the enslaver's children could receive milk. And I don't know, that realization just stuck with me somehow, and it underscored how breastfeeding is deeply intertwined with our history, with resilience and like an ongoing pursuit for liberation. So today, BEMFA, which is short for Black Mothers Breastfeeding Association, is really at the forefront of transformational change, centering Black women in our initiatives, and also doing this in collaboration with esteemed partners. So we're integrating care across health systems and community-based services, creating networks of support for Black families throughout the perinatal period. And really, this work for us is more than about service provision. It's also about systemic change, and uniting stakeholders and fostering a supportive environment. And so we're excited about what we're doing. We're happy with the results of our work, and we're really uplifting Detroit families to make a lasting impression on maternal and infant health and the outcomes in our community. I could go on and on about my inspiration. Thank you for having me here.
Thank you for being here.
Okay, I'll go last but not least. So it's really inspiring to hear from Angie and Kiddada, who I actually get the pleasure of hearing from her a lot. And she has been a part of my own breastfeeding journey. So there's so much respect and admiration there. But for me, coming into this work was kind of a different path, I think. As a public health student, I was just really interested in working upstream. And I remember one of my first professors talked about being able to work ourselves out of a job. And that got me thinking almost exclusively about equity from a systems and a policy change perspective, which is how I ended up with the dual master's with public health and public policy. But I didn't really have a passion area in public health. And I was very jealous of all of my classmates who knew they wanted to work on this issue or that issue. But I was really just very generally passionate about health equity and social determinants of health until in one of my very first public health jobs, I was working as a policy analyst at the Detroit Health Department, and I got partnered with an epidemiologist to review the fetal infant mortality review data. And I was very young, in my very early 20s, doing this work. But I remember looking up at the epi as we were going through the data and making recommendations and saying, so if I want a healthy baby, I just need to be as healthy as possible before I get pregnant and then get good prenatal care. Like, we just simplified it so much. And then we thought we were brilliant. Like, we just cracked the code. It's not rocket science. People should, be able to take better care of themselves and be informed. And I considered myself a pretty informed health consumer. But I fast forward a couple years, I got engaged, and I was bragging and telling everybody about how I was going to get married, including my OB-GYN on that first appointment. And I remember her stopping and turning around, and for the first time ever in my care with her, instead of just asking me what birth control choices I wanted, she actually talked to me about preconception health and what I needed to do and how I should come to her for counseling. And the feeling I had from that was actually a feeling of resentment. and feeling judged because, and throughout my entire reproductive life, there was no support for me going into a healthy pregnancy until this physician decided or judged for me that now was a good time for me. And it made me think about any missed opportunity that not only I had, but a lot of other women were having these missed opportunities to receive the kind of care that they needed to have that healthy approach to a pregnancy. Um, and then in my own personal life, I remember about a year before my first pregnancy, I lost a 3-week-old niece to SIDS. And then about 5 or 6 months into my first pregnancy, I lost a 9-month-old nephew who passed away from RSV. And those experiences weren't talked about so much. It was a sad and tragic occasion, but there wasn't support for those families, those nuclear families who lost an infant, or the extended family to address it. So somehow my passion area within public health became promoting the health and well-being of Black moms and babies. And I gathered all of the protective factors I could think of. And of course, one of those is breastfeeding. And I was able to commit myself, and I think through a lot of things like what Angie discussed and the work that BEMFA provides, was able to navigate that successfully for 2 children for 1 full year before cutting them off, because the weaning process is something that also does not get talked about enough, I think. But wanting to create systemic change so that everyone is enabled to make the choices that they want for themselves when it comes to having healthy families is really my why in this space.
Thank you all so much for sharing those parts of yourself, your journey, and even though that was just a short snippet of the journey, like those are really powerful moments, and I can hear like those moments, those turning points for you, and how powerful those have been. Like, um, I'm curious. Speaking of turning points, whether throughout your career or just your knowledge of like uh, history of community experiences, how have societal perceptions or norms related to first foods and breastfeeding changed over time? And what role do you believe that these changing perceptions or perspectives play in addressing the challenges you see in your work now?
Well, I'll jump in. I think uh, over the past few decades, there's been a movement towards more natural care and healing in lots of different facets of our lives. Like we even are more into natural hair care and organic diapers and different things. And I think that that has helped. But I think this period of time where breastfeeding was shunned. I know I will confess I was born in the 70s. And that was a time that it was like for poor people, or it wasn't like everybody wanted formula. Like that was the thing. But by the time my youngest brother was born, it was, let me try to breastfeed my baby. And my mom was considered like revolutionary again for doing that work. And now I think that there's a lot more support for people to breastfeed, but we are caught in this kind of hybrid effect where there's not a lot of knowledge at the community level on how to be supportive of a breastfeeding person. So it's still a mixed bag in terms of the experience people will have.
Yeah, Jay, I agree. Like perceptions around breastfeeding in the Black community have really long been shaped by a mix of trauma and resilience. Even my own experience, as I shared earlier, is like, for some reason, I just always knew I was going to breastfeed. Even though coming up, I didn't know that that was a revolutionary act. I didn't know that that was resilience. But as I learned more about breastfeeding and Black experiences and trauma, I realized that it was a revolutionary act. I had the pleasure of speaking with today with Dr. Rooks from Princeton University, and she's a Black historian on women's history, and she was telling me, we were talking about Ida B. Wells, and we know that she was a political figure. She was a revolutionary figure, but she would show up at these events with her baby in tow, nursing her baby. And so people were thinking, whoa, what is wrong with this lady? Like, we're in the 1920s. Like, okay, you have to carry yourself with a certain decorum. You can't just show up with the baby in tow and you're breastfeeding this baby. Like, what is wrong? So I do believe that there has been like this mix of trauma and resilience throughout. But I'll also say, like, despite like generations of exploitation and systemic neglect, some of us, somehow we've been able to sustain some of these powerful traditions of nourishing our baby. It often goes without recognition. And if you look that the polling earlier about the question of what's happened to Black breastfeeding rates from 2012 to 2022 was very interesting when I looked at the results of what people were thinking. And it was a lot of that they had gone down. But they actually have gone from 60% initiation to 68% initiation in Michigan. And when I started this work in 2007, the rates were 55%. So I believe that we're on a positive upswing. There's more that we have to do because there's more than initiation, right? There is exclusivity that we need to work on. There are so many systems that we have to come together and resolve these issues. But with that being said, I do, as the data is showing, we are on an upspring. And I think also that sometimes you hear about this in pop culture, right? And so that helps along with the perception. But with that said, there's still mixed feelings about breastfeeding.
I will just add that it's for Indigenous people, we actually have high initiation rates. And they're considered, whatever's optimal. But the issue for Indigenous people is that we don't have long duration rates. Like, it's within 1 or 2 weeks that we typically are quitting. As far as like perspectives, I think that it's hard for me to say because this is my world, so I'm in it. So all I see are people that are breastfeeding and giving birth, at home, or using doulas or using midwives and doing all of these things. That's just my world. So that's all I see. So I feel like it adds some kind of bias to it. So I will say that regardless of what is happening or what perspectives are happening, there's still a lot of work that needs to be done. Like that, just because let's say that, rates are increasing, it still doesn't mean that's where it should be. Like, there's still work that needs to be done. So, outside of, pretty much agreeing with what the others have talked about, that's, for me, that's what it is there's still more work that needs to be done.
Yeah, and
Yeah,
I wanted
that's
to,
like I'm sorry, go ahead, Kiddada.
oh, I wanted to add to that. There are a couple things about like kind of being inundated with this. So like my children, for example, I remember my daughter, and I have people in my family who formula feed, but also in the work that we do, we have a lot of people who supplement. So we have to be clear on that. So breastfeeding is there, but there's also a lot of supplementation going on, and I understand it. But I recall when we were somewhere and someone was putting the powder infant formula in the bottle, and she said, "Oh, Mama, they're putting the breast milk in the bottle." And so in her mind, it was all the same. And so I get what you're saying, Angie, about like sometimes you're in the space that you can't necessarily see what's going on sometimes. But there's definitely work to do around exclusivity, around duration, and just making sure that we're kind of keeping track of what's happening.
You know, listening to each of you talk, I was kind of reflecting on like things I've heard in my own family, like how the different generations have talked about breastfeeding, and like some of them, you know, it what I heard was that like when they were parenting their children, when their children were very small, like it was not something that was talked about, as you kind of like spoke to a little bit in past decades. And then how it's then in more recent generations, people talked about it, but there weren't as many supports and resources and community. And I'm very grateful to be living in a time when there are more resources available. I think, and I think it's just, again, maybe it's part of the circles and communities that I belong to, but it seems like it's more present part of conversation than I remember when I was younger even. Um, and so I'm curious to hear from each of you, you know, what are some of those specific resources or supports that you see needed at the community level to better support families in their breastfeeding journey?
Okay, I'll jump in first too. This way, no one else can repeat my answer. Uh, so, one of the things that I am extremely proud of is the work that I've partnered with BIMFA. Henry Ford and BIMFA are partnered um, through the Office of Minority Health on a perinatal health improvement grant overall, but one of our primary strategies is on creating community and clinically linked systems of maternal care. So we are doing what we can to minimize the barriers that our patients and community members feel to doing things like breastfeeding. And one of the strategies that we have is by training breastfeeding peer counselors through BIMFA. BIMFA is the trainer and employer of these peer counselors, but then they have clinic days where they are rotating in some of our clinics that have the highest Medicaid eligible populations, so that this isn't an external thing that people have to go and seek. They can get that initial support while they are still pregnant to prepare to be breastfeeding parents, and then again encounter them and develop a relationship so that they can have the home visits and all the supports that the breastfeeding peer counselors provide. But I think, like, higher than that, when I think about the kind of just system level and policy level changes that we want to pursue, it is about removing barriers and making it as easy as possible. So doing things like having the co-located services, but then also having policies that are actually supportive of first food friendly lifestyles. Like, I can think of everything that ranges from being able to trust that your daycare center will properly store and distribute your breast milk if you are pumping and providing it, or having some place, the time and the respect really to honor people who want to do that while they are in their work day, is another overlooked struggle in this space. And don't think that if a lot of like our maternal health data shows that education and income are not the protective factor that you would think it would be. I feel that same way too, because I had to break rules literally to be able to pump and store milk in a lot of cases myself. And then even having the peer counselors, or I think a lot of what Angie talked about, like being in the community and getting the support and not over medicalizing something like breastfeeding is like one of the cultural shifts that I think needs to be called out more. And I'll pause there before I go on the soapbox.
Well, Jay, I was about to talk about the Triple Crown grant, but thank you. So we're in an amazing partnership with Henry for Health, along with other community-based organizations, in addition to BEMFA, through a 4-year award, a $4.8 million award from the Office of Minority Health. And it's like our goal is to integrate community-based maternal support services, which is another fancy word for community health workers, community breastfeeding peer counselors, community-based doulas. But one thing that I like to always remind people is that although like community-based care and community-based organizations and grassroots work and all these things are powerful change agents, like we cannot bear the full responsibility for transforming the systems. So we need aligned action across public health systems, hospital systems, philanthropy, and governments. Like we cannot be the persons who are responsible to fix what institutions have refused to reform. And so we need institutions to partner in this work. We need institutions to really listen to, center the voices and lived experiences of families who have been divested in and marginalized, and really not thinking that families are passive recipients of care and that they're experts in their own care. So when these decisions are being made, our families and our communities really must be involved in the change and the care. And that's what's really exciting about the partnership that we have with Henry for Health, with our breastfeeding peer counselors. And one of the things that's always near and dear to me is like that gap of care when mothers leave the hospital and they go home and who's there to support them. Well, we're here to support, we're here to support our families, but how many of our breastfeeding peer counselors exist? And how are we making those strategic connections to the health systems where they're birthing, and trying to fill in those voids and fill in those gaps of care? So um, Black families, Indigenous families, we're here, we have lived experiences, and we're experts in our own bodies and our own care, and what we have to say matters in those experiences. So that's my soapbox. I can go on and on about that, but we definitely are not trying to bear the full responsibility of transforming a system that we did not create.
Yeah, definitely. I will add that, this is this is a question we could go on for days and days and days about. So I'll try to keep it short and simple. Some examples of resources that would be helpful for Indigenous communities specifically would be funding for education for training lactation consultants that look like us, that come from our community. Resources for those of us who want to become IBCLCs, because the whole IBCLC system, again, for those of you who don't know, International Board Certified Lactation Consultant, it's managed is not the right word, but I can't think of it, but they're the overseeing group, IBCLE, as an organization. It's very, oh, it's very exclusive, we'll put it that way. It's inaccessible, it's expensive, and the knowledge that's considered the gold standard for lactation consultant knowledge in the medical world. So, hospitals will only hire folks that are IBCLCs. Well, the problem with that, one of the problems with that is that the IBCLC program was written in like the 50s by two white women, and that knowledge is still the knowledge that is used to teach all other IBCLCs, and it doesn't take into account communities of color, people of color, and how our communities, what our lived experiences are. And so, that being said, there are some Indigenous folks who do want to become IBCLCs, and we don't knock that at all. We love for them to do it, but it's inaccessible to them. It's very expensive. The way the whole thing is set up is, it's just it's not accessible for the most part. Other things that we could use, it should be normal that the first time anybody asks a pregnant person what they're planning to do to feed their baby, that shouldn't come after the baby is already here. Like that should have come, and it should come before the person is even carrying the baby, right? Like these are conversations that should be taking place well before you even have a baby. But the problem with that is that in my personal opinion, breastfeeding, lactation is a thing that all of us should know about, but we don't know that we need to know it. Like, so if you just put out there, hey, we're doing a free lactation course, the only people that are going to take it are people who already have an interest in lactation. But the people who need it are the ones who are not necessarily the ones that are signing up for the course. Everybody should be learning about it. And here's why. Because breastfeeding is a community responsibility. It's not a responsibility of the birthing person. It's not a responsibility of the partner of the birthing person. It is not grandma's responsibility. It is everybody's responsibility. It is the community's responsibility. In order for breastfeeding to be successful, it takes an entire village of people in order to make that happen. And right now, we just don't have systems that are designed to support that. So another example of resources, the video at the beginning of the webinar brought up Cami Goldhammer. Cami is one of my best friends. I work with her all the time. And she's the one who sort of inspired me to do this work. She talks about she's the one who like is kind of leading the charge in a lot of this work. But anyway, why I'm sharing with you is that she started a nonprofit where she's from in Seattle, where they have it's called a guaranteed income program, and they give pregnant postpartum folks, and maybe while they're pregnant too. I don't remember if it starts after they have the baby or if it starts before they have the baby. But anyway, they have 24 months of guaranteed income. So the pregnant person does not have to return to work 2 weeks after or 2 days after they give birth. And that is a huge opportunity for folks. And it's also something that is desperately needed in communities, especially in Indigenous communities, because most of the jobs that we have require us to return to work within a day or two. Like we don't have, work or the resources to be able to just decide to stay home. I was able to stay home, and I'm very privileged because of that, because of the income that my husband has. If I didn't have that, I would have had to return to work immediately too. And so we need things like that, like those things need to be normal. And then again, this is a system thing that Kiddada was talking about. Like we're always trying fit ourselves into these systems, but we did not make these systems. We didn't design them, and they weren't designed for us. But one of the system changes that really does need to take place is full like paid maternity leave for parents, like for a year, not just, whatever the current normal is, and for everybody, not just folks who have a well-paying salaried or unionized job, right? This should be for anybody who's having giving birth. So that is just one of, some of the resources. Oh, in my community, uh, funding for folks like elders in my community. My mom, for example, who takes on a huge burden of caring for my son, and she did especially when he was younger, when he was still breastfeeding. She had to come to, like, when I would go to conferences, she came with, because I needed somebody to, I couldn't leave him home, because the only way for me to breastfeed him is if he was with me. And so if I can't leave him home, then I need to bring him with me. But then I need to also bring my mom with me so that she can take care of him. So now my expenses are being doubled, because I got to pay for her and me and get a hotel room and pay for food and all these things when I'm out here doing work, because she is doing what our community does, which is elders and relatives step in and care for our children. And so if there was resources of just, giving my mom some gas money, right? But the way the systems are designed, like, oh, whoa, why would you need to give your mom gas money? Well, I know why, and it's a valid reason, but I'm not going to sit here and explain it to people who don't have the same lived experience about why that's important and why that is key to us having a successful breastfeeding relationship, is having folks in my community, like having resources to help the folks in my community who are also helping me.
So you would be music to my mother's ears right now. And I know Jay, it feels the same. My mother took care of my children from the time I returned to work until they were 3 years old. And so that looked different depending on what I was doing and what day and where I was in the world. So I second that. Thank you for sharing that.
Yeah, actually, it's not my mom that will be cheering. It's me, because I'm the one who paid for all of her expenses when I took her to conferences and things like that with the baby.
Yeah, Angie, thanks so much for mentioning that about like that it takes a village. I think that's in some way I want to hope that it's something that like folks are generally aware of, but I'll admit like before becoming a parent, like I myself like I didn't even know like how deep that really how like deeply important that is. Like after I became a parent myself, like I was like, "Oh man, I wish I could have shown up differently for my friends and family. Like, I wish I would have known differently earlier, so that I could have been there for them in a different way. But now that I do, like, I am showing up, like, to everyone that's having kids around, like, showing up with food and offering to come and clean and do whatever you need me to do. I'm there for it. But it's such like an important thing is like how um, are we continuing to be that community, that village in all those different ways, and also like continuing to amplify what you're saying about, making sure that those resources are there to support those that are in stepping up into those roles, those extended kinship roles within our families and communities to support us and our families. So I just have one more question before we shift to questions from the class and from other community attendees. Um, so our class is made up out of students from across disciplines and community members attending. And I'm curious from each of you, what words of wisdom or calls of action would you like to leave them with tonight?
So I'll start here. So I'd say that if you really care about food systems, then you really must care about the first food system, because breast milk is the first food, or human milk is the first food. And justice should start at birth, right? We have to start at birth. And so, regardless of your field, whether it's medicine, public health, education, policy, there's a place in this work for you. Really, truly think deeply about those intersections. Um, really start listening to Black women, Black birthing parents, investing in community rooted and community led models. And that this is hard work. And sometimes things that you do take a long time. However, there are immediate rewards too that you find in the work. And so I like to share that because as students, we're visionaries, and you're looking for like immediate results. I want to share that there are some great rewards in the work that you do. Today we celebrated, oh, this is Community Doula Week. And so we had a celebration for our community-based doulas who we've trained, 12 cohorts of community-based doulas. And I planned on going to lunch with them for like 30 minutes, and I ended up staying down there for the full 2.5 hours because it was very rewarding. Like, it was such a good feeling to celebrate the work that they were doing. But also to know that I had something to do with it. I'm not gonna act like I'm not gonna act that humble that I don't know I had something to do with it. So it felt rewarding. So find your reward in the work that you do, even if it's a long-term success plan. I'll end with that. Look for your small rewards in the work that you do.
I'm not really sure how to put this in a call to action, but so maybe it's just considered a words of wisdom. I don't know, but what we need is for cishet white men to stop being the ones that are making decisions for our communities, for our health, for, you know what I mean? Like we hear all the time, like Kiddada just said, listen to Black women, listen to Indigenous women. Like people say that all the time. And it's true that that is what needs to happen, but flip it, right? And say, I need these white men to stop making decisions, making policy, because um, for the most part, they just don't know what the heck is going on and they have zero clue. Um, let's see, call to action. I would ask folks to be intentional and to find a birthing person that you know of in your community, whether it's they've already given birth or whether they are giving birth soon, and you know, dip your toes in and see what it's like to support a birthing person in a breastfeeding journey. Do what you can, and if you have, you know, if you have questions, there's lots of folks out there that are willing to give information and to share information. And so I would say, yeah, if you're interested in this type of work, you just got to dig in and do it. Even if you think that you don't know, a lot of us didn't, and we're still out here doing the work. So that's what I'd add.
Yeah, it's hard to add anything besides I agree. I definitely am on the Trust Women train, and the only other thing I can think of is for you all to be the champion that we need. One of I recently heard a talk where they said that one of the most commonly felt human emotions is a regret. And I immediately when I heard that, I started thinking of the regrets that I've had in my life. And one of them has been not speaking up myself when I've had the opportunity to protect or enforce or support Black women in breastfeeding. So, or women in breastfeeding in general. I kind of alluded to it earlier, but even in my own breastfeeding journey with my first child, I worked in a corporate setting that had a lactation room that actually was a converted bathroom that they had just put a separate lock on that door. And it was 3 floors away and took 10 minutes to walk to and was a real kind of pain and not a pleasant experience. And I remember um, my office, I had the privilege of having an office with a door with a lock and going to the store and buying one of those temporary shades and sticking it up over the window of my door and pulling it down. And um, I remember one of my colleagues saying like, "Oh, good for you. You figured out something." And I felt horrible that I had only figured out something for myself. And I did not do anything about all the other people in my building who had to trek to this one room that was actually a bathroom that had a separate lock on it that you needed the code for to pump. And that had stayed with me 13 years later as a regret. So I want to tell everybody here to just be the champion and speak up and say something and take the risk because without that, we won't be able to move the needle. I have since advocated for more breastfeeding support within my workspace, but that sat with me for a long time as a regret, and I don't want anyone else to feel those regrets when you have the power to do something. Yeah.
Thank you all. So kind of shifting to questions from the class and from community members, our first question that came in was wondering if we could hear more about the poll question about if a baby can't breastfeed, it's their fault.
Yeah, that was my question. What that question is rooted in is that um, if there's a like a physiological problem with breastfeeding, it doesn't mean like I wasn't referring to like mom can't breastfeed because she has to go back to work in 2 days. Like that's a complete separate thing. I'm talking about just the physiological, what's happening. For some reason, it's not working. It's something is wrong with the baby. There's issues with the baby. They have tongue ties. They have, um, you know, they're shallow latches. They have poor suck reflexes. That those are the things that are going on, and it's really a lot of times we'll have as birthing people will assume that it's our fault when breastfeeding is not successful. Um, and we really need to change that because it's not our fault. It's not, you know what I mean? Like it's because of the baby. And again, this is also if you're excluding, trauma to the breasts, right? That might be a reason why a baby cannot nurse from the breast because there's trauma to the breast, meaning severe trauma like car accidents or cancers or, sometimes breast reductions or breast enlargement surgeries, those types of things that actually change the physical structure of the breast. Outside of those things, yes, it's the baby's fault. And that's not all, and also we need to recognize that that's not a bad thing either, right? Like it's not like when we say fault, we always, you know, associate that with like negative feelings. It's not like, we need to just go and be mad at the baby because the baby can't breastfeed. We need to figure out what the problem is and fix it. And so yeah, if like I said, barring those physical issues to the breast, damage or trauma to the breast, it's yeah, when there's issues going on, it's really the baby, and there's an issue with the baby and the baby's physical ability to nurse at the breast. And so that's what needs to be corrected and figured out.
Thank you for expanding on that, Angie. Kind of a related question for all of you. So for some parents, breastfeeding is not a viable option for maybe different reasons. And you talked about some of those, like if for different physical reasons, like you had mentioned a few of those, Angie. What do you suppose that parents could do to ensure food security and food sovereignty for their babies? Would pathways to access breast milk from other mothers and parents be an ethical option? This is a question coming from Anonymous.
Yeah, I'm interested in knowing what viable means in this sense, right? Because
Same. That was my first question.
it's
What does
hard for me
viable
to
mean?
really answer this question because it could mean different. Like I don't know what viable means, but I'll share like in general. So during COVID, I feel like 2021, there was a formula shortage, right? And so breast milk or human milk kind of became a viable option for people, but there was still some mixed feelings around that. And so one of the things that we did was a kind of like a community milk sharing introduction where you could meet women who are willing to share their milk with you and get to know them better and get a feel and see if this was something that you're interested in. So I will say that there are safe ways to community milk share, or what some call informal milk share. I prefer to say community milk share. But I got to know more about that viable. Angie, what were you thinking?
Oh, yeah, I was just going to say the same thing. The answer to this question depends on what is meant by somebody, breastfeeding not being viable. Um, and for me, I will address that, which is I feel like, and because this is from like my experience with people, is um, people will think that they are not making enough breast milk. And so they quit. And the reason for that is well, there's several reasons for why they think that. Again, I'll end up on a grandstand talking about this as well. But for the most part, a very large percentage of birthing people are able to produce breast milk in adequate amounts. Um, so for folks who think that they're not making enough milk, what's happening is they're misreading infant feeding cues. And so they think, oh, like I just fed the baby 15 minutes ago and they're hungry again. I must be starving my baby. That's not how that works. That's not the case. They also compare pump output to what they should be, when people don't respond to pumps the same way that you would respond to an actual baby. So you might not get as much milk out. And then also we're comparing milk production pictures on the internet in these Facebook mom groups that just drive me insane because they glorify these bottles that where a person pumps like 6 ounces per boob each time they pump, and like that's not normal. That is not normal, but that's what gets cheered for on the internet. And so it makes people who don't make that much, who are only pumping 1.5 ounces from each side, makes them feel like they're not making enough when the reality is they're making plenty. They're making exactly what their baby needs. And so I feel like the viable part, that's where that comes from. But again, this is just because of my experience in community, which is that most people say breastfeeding didn't work for me because I wasn't making enough milk. When the reality of it was they probably were, they just didn't know it and didn't have the supports they needed to talk them through it. So yeah, that's all I'll add to that.
So another question from another anonymous submitter. Historically, Black, Native, African American communities whose knowledge systems have been marginalized and erased due to colonialism possess a wealth of wisdom in maternal and reproductive health. How can we revitalize and integrate this traditional knowledge, particularly from doulas and community healers, into modern maternal healthcare practices for both new mothers and healthcare practitioners?
So I'll say, I do agree that to some degree there's been some knowledge blocking, but there are some folks who have been able to capture a lot of this missing information. And I know Mama Shafia Moreau is actually working on a book, I believe it's supposed to be published next year, around traditional models and traditional birthing and feeding practices for Black Americans. So with that being said, sometimes you have to dig a little harder to find the information, but the information exists. And so I'm excited about her book that's coming out. She did a class for us about traditional birthing and traditional healing and so forth. So you have to look for, sometimes you got to look for the matriarchs in the work who've been doing this work, and they've been around and doing it long enough that they have these practices, experiences, and knowledge that we can all learn from.
I think that's such a dynamic question. There's not a simple answer to it, because there are some pearls of wisdom out there that we need to uncover, and then there's also misinformation that needs to be we have to re-educate on. But I think if we go back to the shared message we all had around trusting women and trusting our bodies and our judgment and trusting even our babies um, as they are in this space, there's comfort in that. And just I work for a healthcare system, so I want to be careful about not saying too many times to not over medicalize um, the experience for people. But one of the most remarkable moments in my parenting journey around breastfeeding, with my first child, I struggled more than with the second one. But because of the struggles I had with the first one, I was prepared to struggle with the second one. But I also switched from an OB to a midwife. And I remember when my baby was first born, me telling the midwife, like, okay, give me a minute. I know this is going to take me a while to get the latch right and yada yada. And she was like, what are you talking about? And she had me to just lean back in the chair, take my gown down, and she just set the baby there, and she was like, don't do anything. And then I watched my baby scooch himself, like a day old, to my breast and just latch himself. And she was like, this is natural. Just let it be. And I had creams ready. I had drinks ready. I had this little contraption to attach to myself to attach the baby to ready, because I had already bought into the capitalistic medical approach to breastfeeding and found out that I could just trust my body and my baby, and we would figure it out. And I know that minimizes challenges. So I was someone who had experienced a lot of challenges, but I think if we try to deconstruct a lot of things that we were just made to believe, that we could find the solutions within our community. And when we do, we can embrace those and spread them. Because of course, after that, I told everybody, just see what happens. And it works for a lot of people. Some people still had, more challenges, but we have to share what we know.
I'm gonna say, from a personal standpoint, and I do not speak for, all Indigenous people or all Anishinaabe people, but to be perfectly honest, I don't want to share those things with the medical complex. That's not my job. My job is to take care of my community and my community members. And breastfeeding is ceremony. It's an active ceremony in our communities. It's so much more than just a way to feed your baby. There's so much healing that's going on for the birthing person and the baby. Just in the few years that I've been doing this work, the number of people that I've talked to, that I've heard their stories about how healing breastfeeding was for them, like was able to repair their relationship with their own child or with their own mother because of breastfeeding or because of this work. The amount of healing that I have been able to do as a result of breastfeeding, it's insane. And um, so a lot of the things that we are doing in our communities is it's ceremony, and it's not something that we would just be free, willing to share in like more public spaces, because these are sacred things that are taking place, and it's just not something that we would share. So that's me though. I'm not, I'm happy to share general knowledge, right? But I'm not gonna, um, yeah, I'm not gonna teach specific things that we do in ceremony. You know what I mean? But you know, yeah, it is something that's definitely natural if you think about um, human evolution. It's what our bodies were designed to do, and our bodies and our babies know what they're supposed to do. So
But I guess along that similar type question, specifically for you, Angie, uh, what what are some ways that perhaps medical professionals or medical systems settings can support not extracting that knowledge in any way, but what are ways that medical professionals could support that um, cultural, ceremonial, spiritual, um, I guess, role or significance of breastfeeding?
it's hard because it really depends on like facility. It depends on the healthcare professionals that work there. It also depends on the community and the indigenous folks that are clients of that facility. Um, there are some, in a perfect world, at least what I could envision right now would be a space that allows just as much as you would allow a nurse into the room to be, caring for the patient, that it would be acceptable for elders to also be in the room, or, um, traditional midwives to be in the room and providing care for that person. But the way the system is set up, that's not how it is. Like I said, I hospitals won't hire lactation consultants unless they're IBCLCs, right? And like our community, we don't need that certification. I don't need an IBCLC certification in order to um, teach people in my community about lactation. Um, but the hospitals are only going to hire folks that have those letters behind their name. And so it's really, but then you get into, insurance, like people, the hospital has to cover their butts. And so you know what I mean? So it's just, it's very complex. Things can be done, an example, um, the hospital in the community where 100% of Indigenous folks in my community give birth at, unless they give birth at home. It's the only hospital in the area. Um, they just redid their like it's like an intake. It's not an intake. It's kind of like a birth plan, but it's not a birth plan. It's like a cross between an intake and a birth plan. And so they redid it, and they took and they asked questions that are more supportive of indigenous ceremonies, like and so that's an example. Like it asks if there's, sacred medicines that they would like to bring into the hospital room with them, right? And so it's just even if that question doesn't really need to be asked, because as an Indigenous person, I can bring those medicines with me if I want to. I don't need to have permission from the hospital to do that. But seeing that on paper lets folks know, oh, I can do these things. And maybe they are supportive of me, because really, for the most part, we are not trusting them with anything. So we're kind of like skeptical of the care that's going to be provided. But little steps like that, even if healthcare providers were just asking questions, is there a a specific ceremony that you do when giving birth, or when you are breastfeeding, that you could share with me, even if it's just for their own knowledge, right? It like shows interest in that this is a person that can hopefully be trusted with your care. So, but there's some hospitals, or I just learned about this week because I was presenting at a different conference, that there is a hospital, and it's probably in Canada just because Canada is better. They have a space there on the hospital grounds where Indigenous family members can build birth fires, so they can build a sacred fire. Right. And so like that would be awesome if like hospitals provided a space for folks to build birth fires, or whatever kind of sacred fires are needed. Right. So those are just like some small examples. But it's a big ask. So
Thank you for sharing all that. I got goosebumps just thinking about that. So we're coming up on time. I just want to extend a really big, warm thank you to you all for all that you've shared, both from your personal stories and your the work that you're doing in your communities, all that you've offered to us today, the insights from those journeys, for us all to learn from. And thank you so much for sharing parts of yourselves and part of your evening with us. And at this time, I'll welcome Sammy back to offer some last announcements before we wrap up this evening. But thanks again, everyone.
All right, looks like we're quickly going to do this last poll question before Sammy gives us our closing messages. So running this one in iClicker, and we'll be running it in the Zoom call as well. So after hearing our speakers, which factor do you believe has the biggest influence on a family's ability to choose healthy first foods? And there's no correct answer here. We're just sort of gauging what you think. So most people are saying A, access to affordable fresh food. And it looks like the second most chosen answer, both in the community and in our class, is C, information or education about the benefits of breastfeeding. Give this maybe 10 more seconds for our students to get their answers in. All right, thanks everyone. Sammy, I'll pass it on to you for our closing remarks.
Yeah, thanks, Taylor. All right, so just a reminder that we have Fast Food for Thought on April 15th, and I'm excited to share that there'll be a reception afterwards with appetizers and desserts. So after hearing these 10 amazing faculty and staff members give their talks, you can mingle with other students or talk to the faculty and staff about their presentations. I just wanted to share, these are a few of the presentations, most of them actually, so a variety of different talks on everything from the role of women in agriculture to food and politics in Cuban America, food sovereignty, thinking about physical activity and its connection to food, campus food systems and movements happening here at the University of Michigan. So definitely looking forward to hearing all the amazing speakers on April 15th. That'll be in the Dana building on campus in room 1040, or you can join us virtually But for students, we ask that you do come in person on April 15th and enjoy the food there. This is a form. We shared it last week, but it's from a student who is an adoptee herself and is interested in exploring the nuances of the transnational adoptee experience, especially in relation to food. I'm just going to drop the link here again for the survey. If you do identify as a transnational Asian American adoptee and would like to contribute to this amazing cookbook, you can add your recipe at the form. And this Friday on April 4th, there'll be another one of these seeding dialogue events on campus. The event will be on paper making and thinking about seeds as deep time technologies. Super cool. And lastly, just to share our speakers for next week, we will be hearing from Damien Rivera and Rosemary Linares on their Damien's Craft Meats LLC, where they're co-founders. They will discuss their decade-long journey to establish a sustainable and equitable local meat processing business. The talk will delve into the systemic barriers that they've encountered and the opportunities they've leveraged, as well as actionable strategies they've developed to confront racial inequities in the food system. So highly recommend coming next week if you're a community member, and for students, we'll see you next week. So thank you again so much to Kiddada Green, Angie Sanchez, and Jaye Clement for sharing your wisdom and insights for tonight's talk on equity for first food and breastfeeding. I hope you all have an amazing evening. Thank you so much for joining us.